Thank you for joining me today for a little interview because I have a lot of clients that I find ask me a lot of questions about, whoopsie,
Whoops.
about the under eye and
Right,
the eyes, right? And I met you when we went to Turkey. I guess it was last November, December when Michael
right,
and I joined you there. And I met you originally when I was in training for a Teoxane event and actually
right.
a cadaver event, at two of them actually. And I was impressed by your education and your personality. And I think when choosing a surgeon, you want someone that you feel comfortable with, obviously, to talk to about your concerns. And so I reached out to you, and you were kind enough to do some Zoom calls with us prior to our surgeries. And then we met you in Istanbul and had our surgeries last late November, December.
Right, right.
Um, so, how do you find most of your clients over internationally find you? Is that sort of how, or I know that in Istanbul you have kind of an international center there that actually people go through, right?
Right,
Generally to
right,
find
right.
you. Yeah.
Yeah. So, generally speaking, I don't really do a lot of online advertisements. So, for that
No.
reason, I don't really do like lots of advertisements. But because I tend to travel a lot around the globe, I have a good network of colleagues and also people that I just correspond with, especially through education and also academic or scientific meetings. I
Hmm.
think that's where I build my network, and I find that that's
Absolutely.
a lot more solid than putting out, like an ad for a surgery, which I get is obviously one of the main ways to really, initiate
Hmm.
contact with the patient. But for me, I find that being able to just connect with them through
Hmm.
an event, and then from then on, or maybe connect with
Through a
someone who
colleague,
knows
even.
that
Yeah.
person. Yeah, so it's like a reference of someone who knows me. I find that that's just a more solid way of bonding a relationship between a patient. And like you said, oftentimes I do get a lot of patients, interestingly enough, who do email me or just text me through Instagram or some other social media. And
Hmm.
they'll just mention that somehow they have crossed paths with me or they've known someone who has and they're referring me, or it's another patient of mine who has had
Right.
this journey with me and they want to, maybe also plan a surgery. So
Right.
how basically I connect, first of all. And
For sure.
I find that it's definitely more fulfilling that way because I think that we already have a good foundation for a good relationship with my patient when it's set on just a better foundation, basically, and better basics.
Right, right. When I find my clients, a lot of them come in with under eye, either lines under their eyes, a lot of laxity under the eyes, or a heavy lid, where they've got that extra skin up there.
Right.
How do you decide whether someone is in need for an upper or lower bleph rather than a skin pinch? I know for me, I had the extra laxity under there. Really, my upper lid is fine. So obviously for me, I wouldn't need an upper, but how do you determine when someone's kind of ready for that bleph of the upper or lower lid? I know in Canada, sometimes it's covered at a certain, when it gets to sort of bad enough, right? But sometimes
Right.
it's so bad that people are just wanting to go ahead with a surgery. So
Right.
how
Right.
would they know
Absolutely.
when it's kind of appropriate?
So what you mentioned is obviously if there is a very, very significant amount of skin
Hmm.
over the upper eyelid, especially, this might even cause issue with function, meaning when they're, driving, when they're reading on
Hmm.
day-to-day activities, they might feel the heaviness, or they might actually feel that a certain part of their eyesight is blocked because of the skin sort of just
So more their
layering over
peripheral
their
vision.
sight. Yeah. So in that case, obviously, I think many countries would really find a way to use insurance to cover that. But generally speaking, I think that that would be like the most extreme version of the issue. Whereas oftentimes, you're going to notice when you have sort of an excessive amount of skin on the upper eyelid, and that is usually noticed when, especially females, they tend to see that they have a hard time putting on makeup. They have a hard time,
Hmm.
just doing their flick out of the liner, or they feel that,
Right.
even though they put on their makeup, somehow it's not staying put, it's smudging a lot more. And
Okay.
when they look at themselves, they see sort of those extra flaps of skin over their eyelids. So those can be potential clues that you might be a good candidate for upper eyelid surgery. But it's important to be able to distinguish whether or not the issue is from the eyelid or from the brow, because we
Okay.
also know that with age, the brow can also descend. So we can also have brow ptosis. And when
Right.
that happens, the position of the brow sort of just droops downward, and
Hmm.
that heavier brow skin tends to fall on top of the eyelid as well.
Right.
Now, both of them might actually look like you have extra skin on your upper eyelid, but they're very different. Because if your brow is in its correct position, so for you, for example, it's in a very, very optimal position. For me, likewise, I would say it's in a pretty good position. I just got my toxin,
Right.
so it's fine.
Yeah.
Generally speaking, for females, the brow is positioned above the bony rim, so above the suborbital rim. That's where my bony rim is. It's positioned above it. That should be the correct position. Of course, certain people have higher brows, certain
Hmm.
people have brows, but in general, for the female face, the brow has to be positioned above the rim. If you have a brow that is positioned at the rim or even below it, that means that you have a brow ptosis, a brow descent. And in that case, that tissue that is sort of that thicker tissue of the eyebrow is going to actually fall over your eyelid as well. Now, here's the
Right.
most important part. Unfortunately, not everyone is as I would say, qualified to do eyelid surgery as someone who is qualified. So, unfortunately, lots of people in many countries will try to, do surgery on patients even though they don't have the qualifications. And this is one of the main, I would say, downfalls of getting a blepharoplasty with someone who is not qualified. The thing is, if you have a brow ptosis, which like I said, can actually be something that's quite common, and if
Hmm.
that person who is evaluating you will not acknowledge that and just simply do a removal of the skin, what happens is it actually brings the brow even closer down because you tend to remove that brow skin
Hmm.
and you transpose that thicker brow skin onto the eyelid. So in that case, you have a patient who does not look refreshed at all, looks even more tired, maybe even more masculine, because we know that males have lower set eyebrows compared
Hmm.
to females. And this can obviously be an issue. So the first thing is to, first of all, determine whether or not you have a good position of your brow. If not, that is also one thing that we have to take into consideration. Sometimes we have to combine a brow procedure along with an eyelid procedure, but that's not
Right.
always
Which is
the case.
something you did for Michael, actually,
Right,
I
right,
believe. Yeah.
absolutely. Yeah,
Yeah.
that's what we did, Michael.
Okay, so what about the and what about the lower eye then when it comes to that? Because I mean, going back to my surgery, mine was extra skin under there, right? So a
Right,
skin pinch was done and a fat transfer. And
right,
then I believe Michael had a blepharoplasty in the under
right,
eye. So
right,
two
right.
totally different things. What's the difference between them?
So I wouldn't call them two totally different things, but I
Totally
would say
different.
they are different parts within a spectrum, I would say,
Okay.
kind of. So they kind of add up together, but obviously in different intensities. So the under eyelid area, the anatomy is very complex, much more complex than the upper eyelid and what we do with the upper eyelid. So for that reason, the first thing that we have to do is first of all assess our patient and to determine what the main issue is. So some people might have pigmentation problems. Other people might have just very thin, loose skin with loss of elasticity. Some people might have eye bags, so basically just
Right.
sort of needed fat pads. Whereas some people might have festoons, edema, or
So
just
many
excessive
things.
skin. There's so
Yeah.
many things that can happen. Also, the loss of elasticity might not just be on the skin, but also on the lower eyelid as well. So you might actually have looseness of your skin, your tissue as well, even your tarse. So for that reason, the assessment is our first and number one, I would say, point to cover. And if you have, I would say, excessive skin, you have to determine whether or not you require just a removal of skin, which is the pinch blepharoplasty that we did with
Hmm.
you,
Hmm.
or whether or not we need to go in and also do any kind of treatment to the deeper tissues, including the muscle, including the fat pads. So we have the fat
Okay.
pads, the nasal, the central, and the lateral fat
Hmm.
pads. So for a person who would have eye bags, just a pinch would not be enough for them because we also have to find a way to either remove some of that fat tissue, not all of it, by the way, because we know that it does harbor some volume that's going to actually support the eye. So for that reason,
Hmm.
it still has to be there to a certain degree so that we don't want to have hollow eyes either. But removal of the amount that is too much. Also, if the muscle is too, I would say, loose, then also being able to tighten that muscle almost like
And
apply pressure,
reattach it
of course,
almost.
and reattach it to the bone. And of course, if you have additional extra skin, removing that excessive skin. And that would be what you would consider doing during surgery. And sometimes even we can do a repositioning of the fat, meaning that you take the fat, but you actually distribute it someplace else. So like you mentioned, fat grafting is
Hmm.
also popular procedure there, and mostly because fat, especially not at the level of the eyelid, but just below it on the anterior cheek area, so the frontal cheek area. This is an area where we tend to lose a lot of volume.
Right.
Especially with age, it's one of those areas that we tend to just sort of look and focus on first because aging starts in the mid face. So that's one of the areas that we focus on, especially when we are doing eyelid surgeries as well. Mainly because if we have a loss of volume, it's still not going to look supported. It's not going to look youthful. So we have to support that as well. And sometimes we can do fat injections, but if a patient has excessive amount of fat, we can actually redrape it over that cheek area, transpose
And give
it.
you that volume back.
Yeah, yeah. So we can just redistribute it into areas that require it rather than where it is basically kind of like a
Okay.
Robin Hood procedure. So you take it from the
Right.
rich, you give it to the poor.
Yeah, exactly. So when I think about recovery for those procedures, I mean,
Right.
obviously, if you're just having an upper bleph, it can take, how long would you say before it actually looks like, it's going to look? Would you say a year or would you say less than that?
Actually, no, I think for the upper eyelid, it should be rather quick. I
Okay,
tend to say that a month is a good amount of time to get a general idea of the upper eyelid, mainly because the swelling tends to subside by that time. Of course,
right.
your skin does not, your scar does not mature within a month. It's going to get better and better as time passes. And for that, I would definitely say a year. So
Okay.
year one, it's going to basically look completely
Like it wasn't
understandable.
even there.
Yeah, it wasn't even
Yeah,
there. But
yeah,
in the first couple of months, you will see, depending on your skin tone, maybe a bit of a darker shade or maybe a pinker shade of like a thin line. But
yeah.
generally, it tends to heal very, very well.
And what about
Uh,
the lower eye? Just the
the
lower
lower
eye as
eye.
well?
The lower eye, I think it depends again on the procedure. So for you, it was a walk in the
Super
park.
easy.
I know,
Super
super easy.
easy.
It was a walk in
By
the
this,
park.
by the second week, I could honestly say you hardly knew I had really
Yeah,
much there,
right, right,
because
right,
of
right.
the zip stitch that you did. It was just a tiny little one here, a little one in the corner.
Absolutely, absolutely.
Yeah.
So, with the under eye, it can be a bit more detectable, mainly because with the upper eyelid, the scar and the incision tends to sort of go into the crease. So you hardly even see it when the patient has open eyelids. But for the
Right.
under eye, it's very important to be very, very intricate with your technique when you are stitching because it's actually right underneath your eyelash line. So you need to make sure that, it looks very seamless and very good. But generally speaking, if it's an only pinch procedure, I would say quite similar to the upper eyelid, where you would feel that it hardly even bothers you in the first month. And then
Hmm.
it can just get better and better by the year. But if you
Okay.
have a more extensive surgery, especially if you have the removal of the eye bags, transpositioning, any kind of sort of
Hmm.
or tightening or sort of suturing that tissue to the bone, the periosteum, it's going to take more time because the swelling is going to take more time to heal. The under eye area is a very interesting area, mainly because the lymphatic drainage of the under eye
Hmm.
differs from the rest of the face. I know we've covered this in our anatomy
Yeah.
classes,
Hmm.
so you know that. We know that normally the face drains very effectively all to our neck, but the
Hmm.
under eye region first drains to our preauricular, so our ear area where we have some lymph nodes, and then from there on, it drains into our neck. So for that reason,
Hmm.
it's very delicate. It's already susceptible to edema. So when you have, a lack of sleep, when you've maybe taken an excessive amount of,
Salt
fluid
or
or yeah,
anything,
salt, anything,
alcohol. Yeah.
alcohol, that tends to show first of all in your under eye region. And that's the reason for it, because this is the one area that your body cannot really, compensate for. And it's
Right.
the same reason with that is that if you have extensive surgery, it's going to just take a bit more time for that swelling to heal. So I would say about 3 months. If
Okay.
you have an extensive surgery, similar to that of, I would say, like a mid facelift or a facelift, 3 months tends to be a good time frame for us to really determine how the results are going to look. But scar wise, the scar is still going to heal well. It's just that the swelling can just take a bit more time.
Okay. Do you find that if even after having these procedures and then having maybe laser treatment or something within that first 6 months or a year after having those treatments, you could swell up a little bit more because you have had surgery within that time frame because of the lymphatics? Is that possible?
For That's such a good question, Chris. Maybe not with, I mean, the thing is obviously anything that you do in the under eye region that's already, swollen could
Hmm.
potentially increase the swelling. So anything that would induce inflammation there, whether it's a
Yep.
burn caused by a laser or
Right.
whether it's a toxin where you would
Hmm.
maybe decrease the amount of muscular
Of
contracture.
constriction.
Yeah,
Right.
and that would also maybe increase a bit of that accumulation of the fluid. These things might cause an increase, but I'd say it's a matter of balance. Sometimes I think
Okay.
patients can definitely benefit from having lasers after surgery as well, because there are certain lasers that obviously, will help tighten the skin. And for
Hmm.
that reason, I think it's also maybe determinant of how deep the laser sort of penetrates. It depends on the
Right.
laser that you utilize and, of course, the intensity of the laser.
Okay.
So,
Yeah.
considering that you're with an expert, there's a lot of potential for you to actually utilize those technologies along with your surgery as well.
Perfect. Okay. So, I mean, I guess when it comes to my role in my clinic, doing the aesthetic area, like the working around the eye to help people to have the best result before surgery, to maybe lift the brow a little bit, maybe with some toxins, even just under the brow tail, just to give
Right,
that little lift, or manipulating really kind of where you inject in the frontalis, so you get
right.
that brow to lift a little bit, is always helpful, I find. Do you have any thoughts on like doing what they call like a jelly roll right close to when they have that little bag under there? Or even doing toxins in the under eye. I don't like to do anything under there if they do have lymphatic issues as it is, because I do see that swelling in that area after. But some clients will ask for that little bit under there if they don't have those issues. Do you feel like that's okay?
Yeah, but
Yeah,
like you said, you have to make sure that you pick your patients wisely.
very
So
carefully.
patients who don't really have that tendency to swell on a normal day-to-day basis, I think it's okay to do a very small, like single unit,
Hmm.
just
Toxin.
under that like sort of central part, just for the jelly roll. Sometimes you can go a little bit, here, sometimes because you have those
Yeah.
like beats that are sort of extending like very close. You can obviously do that as well. But I would recommend staying very, very superficial, like very low doses and just treating as you go. But
100%.
like you said, for patients who do have that susceptibility to swelling, it can definitely exacerbate the situation. So I'd be very cautious.
The other thing that I do use a lot of caution with in my clinic is I don't do a lot of under eye fillers. I'm not a huge fan, to be honest. There are specific clients that, yes, they do really well with it, but I feel if they don't have that cheek support, I really always assess the cheeks first to see if they need that medial cheek support because I can get a lot of support there. I find when you do under eye filler, it might look good in the beginning, but later on, I have a lot of clients that come that have had it wherever else or over the years, they come back maybe 4 or 5 years later and it's so puffy. And so
Mhm.
I'm dissolving that area. When you have plastic surgery, do you have to remove that filler prior?
If the patient admits to having any kind of filler, I would recommend to dissolve it beforehand, and I do, and I definitely ask
Okay.
them. Simply because obviously it's a foreign body, and when you do any kind of surgery, it might tend to increase the inflammation of that area. Sometimes, though, it has not happened with under eye areas specifically, but for other areas, for example, the nose, sometimes patients neglect to tell me, they don't tell me, and I get like a little surprise.
Yeah,
Thankfully,
yeah,
it doesn't really create a very big issue. I tend to just sort of scoop it out
yeah.
during surgery, but of course, it can sometimes be a little bit of dark surprise. So I
Right.
prefer to make sure that I ask and I dissolve prior to any kind of surgical procedure. As for under eye fillers, I'd say that there's definitely a good patient cohort who is definitely very, very prone to having a good result, and
Hmm.
also a patient cohort who is definitely prone to having a bad result. So again, it
Yeah.
goes back to assessment. And what you say is basically that exact point that we have to look into. It's cheek support and basically the quality of the skin.
Hmm.
If a patient does not have good anterior cheek support, whatever you do to that tear truck to the under eye, it's not going to work.
Right.
So that's the first thing that we have to assess and make sure that the patient has a good, solid, fundamental, cheek support of
Support.
their face so that you can sort of build on it.
Right.
If you have a patient who basically has that typical hollow, kind of the congenital hollow, who has good cheek support, or let's say, for example, you support
Hmm.
their cheek with HA filler or any kind of treatment, then afterwards
And
you
then
can
just do a little
definitely
bit.
go on and give a little bit of under eye filler. And I think that that tends to sort of be, the icing on the cake for those
Hmm.
patients. And I know that they work tremendously well with that kind of
Hmm.
treatment. But it's always important to make sure that you session it out, and you
Right.
have to make sure that you follow through. I'll tell
Right.
you, just similar as you mentioned, I tend to do a lot of under eye filler dissolving as well.
Hmm.
But oftentimes when I dissolve, patients tend to get very unhappy. So what I
Yes.
do is
So
I
you
dissolve.
really have to talk about that prior, don't we?
Oh yeah. Yeah.
Mhm.
So I dissolve, I make sure that everything is settled, and then I bring them back and I see what the main issue is. And if I feel that they are actually good candidates and maybe they just had the wrong product in the wrong layer,
Hmm.
so basically something was just not correct down the line, I reassess and see if they might actually be good candidates at that new time. And if they are, I tend to redo their treatments as well.
Right. So if someone does have laxity, they have maybe they get the swelling under their eyes. They're not really good candidates for under eye filler, honestly. Even sometimes medial cheek filler isn't a great idea for them.
Of course.
Then we're really the
Yeah.
only alternative really is surgery, isn't it? For those
Mhm.
clients.
I
Yeah.
mean, yeah, it depends, of course, on how extensive the issue is. If you
Hmm.
feel that energy-based devices can also, improve the
Tighten the
quality of
skin
their
a bit.
skin, the tightness, it could happen, and it could be a good alternative because not everyone is a candidate for surgery as well. We also have to accept that. I mean,
Right.
some people are not willing to undergo surgery because,
Hmm.
they might have certain issues with it, they might have some health issues with it, or
Hmm.
they're just maybe frightened. And you have to respect that, first of all.
Right.
Um, but some people definitely are good candidates. And in that case, it's important to make sure to let them know that they have alternatives. But of course, the more invasive a procedure gets, the better and the more I would say, um, significant the result is going to be. But of course,
Hmm.
it's going to have more potential,
Risks.
healing issues. It's going to take
Hmm.
more time. It's going to have more risks. So yeah, it's basically something that every patient has to decide on their own. But considering that everything is done effectively in a way that, assessment is done on point, the patient's general health status is definitely checked upon, the medication history is checked upon, and of course, the assessment is done. Generally, if you are undergoing surgery in a hospital, that's definitely, fully stocked with everything, the whole
Hmm.
technology and capable doctors,
Have you
they can tend
handling
to
everything,
go.
then you'll be fine. Yeah.
Right,
Yeah, well, thank
right.
you. I don't want to tie you up much longer. But I appreciate you so much for this interview, and I'll let you get back to your family and the rest of your evening. When am I going to see you again in Canada?
Hopefully very soon. There
Yeah,
might be potential for me to maybe fly out closer to the end of the year, but in
perfect.
that case, I'll definitely know. Yeah,
Okay. Well, thank you
absolutely.
so much, and we'll talk to you again soon.